Hi everyone. So in this series of lectures, we're going to be thinking about the relationship between mental health and inequality. So in this lecture, we're going to be thinking about some of the kind of more well-known areas of inequality that relate to mental health. So we'll be thinking about issues such as LGBT, race and ethnicity, gender, socioeconomic status. And then in the following lectures, we're going to be moving to think about inequality over the life course. So thinking about inequality in children, younger adults, and then also thinking about mental health issues in older populations. So as a starting point, really, I just wanted to think about the impact of COVID on people's mental health. So this is something that we've discussed in much more depth. So when we were doing the portfolio before Christmas, we were looking at COVID, and mental health was a key factor that many of you thought about. So the pandemic, continues to not be over. And we've already seen some really significant trends in groups of people that might be more likely to experience poor mental health. And whilst there are these inequalities and there are these discrepancies, it does remain the case that actually mental health has become an issue for many more people than pre-pandemic. And some of these reasons relating to mental health during COVID relates to the stress associated with financial loss of employment, frustration at, the continued restrictions that are being put in place, and just the general kind of frustration at not really knowing what is going to be happening in the future. Loneliness and isolation, so particularly for individuals that have had to shield or that live in a household on their own. Boredom, fears of infection, and then also worries about the future and concerns about being able to access goods and services, and especially including those support services. So we know that many of the support services that were available before COVID have had to really significantly change. They've had to adapt to the pandemic. And we know that there are issues with that in terms of how people are able to engage in some of these services that are available. So whilst we know that poor mental health can be experienced by anyone, it does remain the case that discrepancies do exist in poor mental health, and these discrepancies have largely remained the same throughout the pandemic. So we've got a graph on the screen that highlights some of these discrepancies, some of these inequalities in relation to age, gender, ethnicity, and level of education. So what this graph tells us is that during the pandemic, for all groups, we've seen increased reports of psychological distress, and that this has remained constant. So it's been a constant increase across all of the groups. But we also know that this has been disproportionately impacted. This has disproportionately impacted some groups of people. So looking at the graph, for example, we can see that people aged 18 to 24 and women have had significant increases in poor mental health. So whilst there's been increases for all age groups, the increase for 18 to 24-year-olds has been significantly higher. And we can see the same for gender as well, with the difference between men and women. A slight difference can be seen when looking at ethnicity. So the graph shows that the proportion of Asian people experiencing psychological distress pre-pandemic was lower than that of white and black ethnic groups. But actually, throughout the pandemic, that this has significantly increased and is now higher than white and black ethnic groups. So this suggests that the specific context of COVID might have impacted people from Asian ethnic backgrounds much more than others. And, there are a number of explanations for this, one of which we can think about the increase in hate crime experienced by people of an Asian ethnic background because of the link between coronavirus and that it emerged largely within Asian countries. So there are reasons that we can think about this significant increase, and actually looking at the social and cultural context can be really key in doing that. So class inequalities is something that we know is largely associated with mental health. So we know that people that are in the lower categories of social class, so people experiencing more social economic deprivation, are more likely to also experience these throughout life, and have less chance to access buffers that may actually alleviate some of that instability. And we know that this can significantly impact mental well-being. So what I think is really important to recognise is actually that this can be a bit of a cycle. So what we know is that health risk factors and access to the health system, that the odds are stacked in favour of the better off. So people that have good health tend to have good access to the health system and engage in more protective factors so that their health behaviours might also be beneficial. And we know that, on the contrary, for people that are in lower socioeconomic environments, people living in socioeconomic deprivation, are also less likely to have good access to health systems and might actually be engaging in more riskful health behaviours. So the Health Survey for England and Wales has consistently found that people in the lowest socioeconomic class have the higher risk of mental health problems. Debt itself is a key issue, so that people who are living in debt are more likely to have mental health problems, and that then the more debt that people have, the greater that likelihood becomes. What we also know, though, is that there's a risk to mental health if that economic hardship starts early in life, so that children, especially that are living in poverty, experiencing poverty, are also more likely then to go on and experience poor mental health into adulthood. So we've really got then a cycle of money and mental health problems. And what we can see from the image on the screen is that this relationship between money and health problems operates in both directions. So this says that actually being poor can bring about mental health problems, but actually again that poor mental health problems can lead people into being in poverty due to discrimination in employment and the reduced ability to work. So what this means is that it's not a simple relationship between poverty and mental health problems, but actually they impact one another. So mental health problems make it harder to earn, manage money and spending, and to ask for help, so that financial difficulty then causes stress and anxiety. But equally, we know that having mental health problems then makes it harder to earn and to have financial stability. So what this means then is that we really need to think holistically about both poverty and mental health difficulties as related issues that we can't address in isolation. So if we think back to before Christmas, we were looking at models of health. It's really important that we take much more of a biopsychosocial model of health that takes into account the social and economic context that people are in, and wider factors relating to their mental well-being. Now, continuing thinking about poverty, I think it's really important to recognise actually the emotional toll, the additional labour that comes from trying to seek welfare support. And we thought about this a little bit when we were thinking about disability, and that dreaded brown envelope that disabled people often talk about, which is really seen to seal the fate of individuals. But we can apply this more broadly to welfare support. So Ian Porter from Joseph Rowntree Foundation argues that our social security system should provide a public service people can turn to when they hit hard times, but actually there's nothing compassionate about the rollout of universal credit, increasing levels of anxiety and stress among low-income families. Delays in payments, the complexity of the claiming process, and the unpredictability of financial support is forcing far too many people into a corner, leaving them facing impossible decisions. So actually this really demonstrates that, the process of trying to access welfare support in itself can have a significant and detrimental impact to someone's mental well-being. And what it also means that potentially individuals who are already vulnerable to poor mental health are likely to further have to endure psychological stress in trying to receive that help. Now, precarious work is another really important issue when thinking about poor mental health. And we might also come back to this when we look at age, and that actually a lot of precarious work is experienced by younger adults. For example, so precarious employment might include temporary work contracts, zero-hour contracts, casual work, and that this is a really clear social determinant of health. So what we know with these kinds of temporary zero-hour contracts is that there's much less protection in terms of physical health and mental health. So not only do these kinds of contracts offer lower levels of health support, but actually that, the actual experience of being in precarious employment can be a significant impact to someone's mental well-being. So job loss, for example, has a traumatic and immediate negative effect on mental health, and that particularly when that unemployment or that precarious employment continues, mental health can be detrimentally impacted in the long term. So another key issue then that we can think about is mental health for LGBT individuals, so people that identify with the LGBT community. So a report published by Stonewall has some really quite eye-opening figures in relation to this. So the report argues that 52% of LGBT people had experienced depression in the last year, and that 46% of trans people had thought about taking their own life in the past year, and that 31% of LGBT people did. So this is really crucial in understanding that actually the marginalisation of groups like individuals identifying with the LGBT community are also more likely to experience poor mental well-being, and that actually the experience of marginalisation, of stigma, discrimination might cause some of these issues as well. In terms of race and ethnicity, we know through research that Black Caribbean people are twice as likely as white people to be diagnosed as having a psychotic disorder, and that this is particularly the case when we think about schizophrenia. Young Asian women are 3 times as likely to kill themselves than young white women. Black and minority ethnic communities are less likely to access mental health support in primary care, so things like their GP, and are more likely to actually end up in crisis care. So this again is really crucial to understanding the kinds of health outcomes that people have, so that by not accessing mental health support initially, by not accessing that support through the GP, people are much more likely to end up in crisis situations. It's also been proven that Black and minority ethnic people are less likely to be referred to talking therapies, and instead much more likely to be medicated for ill mental health. And I think this raises some really key issues, doesn't it, in terms of the kinds of support that people are offered, and the potential racism that's occurring within mental health practice that could explain this difference in support that's offered. So gender differences we've already touched upon in relation to COVID, but the The relationship between gender and mental health is a bit more complex. So it's not suggesting that women are more likely overall to experience all mental health problems, but actually that women are more likely to experience common mental health problems. So those such as anxiety, depression, and stress. But what we do know is that men are more likely to take their own lives more frequently than females. So whilst women might be engaging with suicidal attempts, that men actually are more likely to commit to this. And this is what's known as a gender paradox of suicidal behaviour. In terms of age, we also know that in 2013, 6,233 suicides were recorded in the UK for people aged 15 and older, and that 70% of these were men and 22% female. So this is a huge difference between the number of men and women that do commit to taking their own lives. And so it's also interesting then, this kind of opens up a series of questions with, why are men less likely to access mental health services before kind of reaching this crisis point? And it also means that if women do engage with the mental health support that's available, does that mean that actually that's really effective in preventing people from getting into these crisis situations? So education is something that we can think about as well in terms of the level of education that people have and how that might be related to poor or good mental well-being. So we know that actually dropping out of education has been associated with substance misuse, mood disorders, and suicidal thoughts. So this one's interesting, isn't it? Because we've not only got education as a factor, but we've also got substance abuse as a potential factor that not only causes people to drop out of education, but then simultaneously has an impact upon mental well-being and the occurrence of suicidal thoughts. And we also know that education is actually really, really important in building emotional resilience and affecting a range of later life outcomes, such as employment, income, and community participation, which we know can raise or lower the risks of mental disorders. So a lot of schools now, particularly primary schools, a key part of curriculum is emotional resilience. It's about looking after ourselves, looking after each other, understanding our feelings and our emotions. And so this can be really crucial in helping young children moving through adulthood, in understanding their own well-being and being able to look after that. But we also know that education for a lot of people is really important in determining life outcomes such as employment, income, and community participation. And we know, for example, that precarious employment, unemployment is linked to poor mental health. And we also know that isolation is a potential risk factor for experiencing poor mental health. So in the following lectures, we're going to be moving to look at a life course approach. So at every stage in the life course, vulnerability and exposure to harmful processes or stresses can be disruptive, which is why any public health intervention needs to take a life course approach. A life course approach implies that institutions such as kindergartens, preschools, schools, university and colleges and employers all need to be involved for building healthier and happier communities. So this is really key in thinking about mental well-being and the stability of mental well-being throughout the life course. So it's about thinking about early influences to mental well-being for children, and potential issues, potential contexts that might impact a child and a young person's mental health, but also about accountability for these institutions that we engage with throughout our lives. So what role do schools, universities, employers, what role do they have in ensuring the mental well-being of people that attend that institution? If you've got any questions, feel free to get in touch, and we can continue to think about mental health and inequality in your teaching sessions this week.